So this is how a whole blood, even if it is a whole blood unit or if it is a packed RBC, it will look the same. Now, what is very important, as I told you over there, in around 349 ml, I was adding approximately 49 ml of anticoagulant. Similarly, this is a bag. Now, it varies with different countries. This is a bag containing 450 ml, containing 63 ml of CPDA anticoagulant. Now, different countries have different codes. Over here, the storage temperature is 1 to 6. We have in our country, we follow 2 to 6 degrees centigrade. Okay. Always remember on this packet, see, there is always a unit number. There is a bar coding which is always there. Once you will click at this barcode, it is going to tell you that it is going to identify the donor and all the details of the donor. And it is containing CPDA1 and it is a whole blood unit and it has to be identical. It is ORH positive. Okay, so these are the different findings that you are going to see whenever you look at a whole blood unit, or even if you look at any unit, these details will be mentioned. Okay, is it very clear to everyone about the whole? So we are going to understand a very important component, that how we are deriving the blood components from the whole blood. Okay, so suppose you have collected 1 unit of the whole blood. So that blood, okay, first this whole blood is subjected to light spin. Okay, so light spin is a method wherein you centrifuge the sample at a lower RPM. Okay, so from there you are going to get first what is called as a packed RBC, and then you are also going to separate the packed RBC from what is called as platelet rich plasma. So after centrifugation, what is going to happen? You are going to get a sediment of packed RBCs at the bottom, and the supernatant fluid that you are going to get is a platelet which is mixed with plasma. So we call it as a platelet-rich plasma. Now the packed RBCs that we get, it can be processed in different methods. So sometimes we can get red cells in additive solution, leukocyte poor red cells, washed red cells, packed frozen red cells, and irradiated red cells. So these are the different types of packed RBCs that you can avail. But remember, in the true practice that we see, most commonly used blood component is our packed RBCs. Okay, so that is why I have highlighted this with red. Okay, packed RBCs, and packed RBCs can have different varieties. Okay. Now, what happens with this platelet-rich plasma? Now, this platelet-rich plasma is subjected to a second centrifugation, which is called as a heavy spin. Over here, we are centrifuging for a longer period of time at a very high RPM. Okay, so over here again, you are going to get certain sediments, and that sediment is composed of the platelet concentrate, whereas the remaining supernatant fluid is the plasma. And from this plasma, we derive fresh frozen plasma and cryoprecipitate. So good morning, everyone. Today we are going to read about the blood components. It is a very important section. This section of blood banking is dealing with the different components that we can derive from a unit of whole blood. And what are the uses of these components? What are the indications? What are the contraindications? Okay. For how much time they can be stored, how they are used, okay, in which way we can use them. So it is dealing with the different blood components. Okay, so we as doctors, as physicians, okay, we should understand, okay, that what are the uses of different components so that we can prescribe the same to our patients. Okay, so before we start, let us go over certain definitions. So what is a blood product? So a therapeutic substance which is prepared from a human blood is called as a blood product. Okay, now what is whole blood? So 1 unit of non-separated donor blood. So when you take a blood directly from the donor, okay, and if you do not do anything to that blood, that is called as a whole blood. That is containing the cellular component along with the plasma component. That is the whole blood. What is the blood component? A constituent which is separated from the whole blood by something called as differential centrifugation. Okay, differential centrifugation means when you are causing centrifugation at first a lower speed, then you are causing it as a higher speed. That is called as differential centrifugation. More will be clear later on in the video. Okay, or that is obtained directly from the blood. Okay, So by a process called as apheresis. I will tell you what is apheresis and I will tell you about differential centrifugation as well. So whenever you are deriving any component from the whole blood, it is called as a blood component. Okay. And then there is something called as a plasma derivative. So we are deriving certain substances from the plasma. So usually these are containing human plasma protein. So human plasma protein, which is obtained from multiple donor units of plasma. And this plasma derivative, they are heat and chemical treated to inactivate the viruses. So these are the four important definitions with regards to the blood components that we are going to understand today. So as I told you that what are the methods of the blood component separation? Okay. So the one which is most widely used, especially in third world countries like India, is your differential centrifugation of whole blood. So 1 unit of whole blood that you have taken, okay, so you are going to centrifuge. I understand that all of you understand the meaning of centrifugation. Yes, it means you give the blood sample in basically a centrifugation machine, okay, wherein the sample is kept over here and it goes round and round like this in a centrifuge. Okay, it is going to centrifuge at an RPM, and that allows sedimentation of the heavier particles. Yes, I appreciate that everyone understands it. This is a basic concept. So basically differential centrifugation of the whole blood, this is the most commonly followed method. That is the method of differential centrifugation of whole blood, and then we get different components. We are basically going to talk mainly about this in this particular chapter. And with regards to apheresis, I am just going to tell you what is apheresis. So for example, if this is a human being, any human being is there, okay. Now from this person, blood is taken, okay, the whole blood is taken, and then it is processed in some machine. It is processed in a machine. It is processed in this machine. And then after this blood has been processed, okay, whatever part was required, for example, I just require the platelet, okay. So I will just take out the platelet from the blood, and the remaining components, they are going back to the donor. Understand? So this is called as apheresis. Apheresis is a process wherein only a particular component which is required, okay, will be separated from the donor, and the remaining component will go back to the donor. This is called as apheresis. Now, depending on whichever component has been transfused, we will call it as platelet pheresis if platelet is removed, leukapheresis if WBCs are removed. Okay. So similarly, when different components are removed, for example, if plasma is removed, then we are going to call it as platelet plasma pheresis. Okay. So these are the two different types of methods by which we are using for component separation from the whole blood. Now come to this very, very important discussion. So we have to understand that how all the blood components have been derived from the whole blood. Okay. So let us try and understand this particular concept. So suppose you have taken, so we are going to understand a very important component that how we are deriving the blood components from the whole blood. Okay. So suppose you have collected 1 unit of the whole blood. So that blood, okay, first this whole blood is subjected to light spin. Okay. So light spin is a method wherein you centrifuge the sample at a lower RPM. Okay. So from there, you are going to get first what is called as a packed RBC. And then you are also going to separate the packed RBC from what is called as platelet rich plasma. So after centrifugation, what is going to happen? You are going to get a sediment of packed RBCs at the bottom, and the supernatant fluid that you are going to get is a platelet which is mixed with plasma. So we call it as a platelet-rich plasma. Now the packed RBCs that we get, it can be processed in different methods. So sometimes we can get red cells in additive solution, leukocyte poor red cells, washed red cells, packed frozen red cells, and irradiated red cells. So these are the different types of packed RBCs that you can avail. But remember, in the true practice that we see, most commonly used blood component is our packed RBCs. Okay. So that is why I have highlighted this with red. Okay. Packed RBCs, and packed RBCs can have different varieties. Okay. Now, what happens with this platelet-rich plasma? Now, this platelet-rich plasma is subjected to a second centrifugation, which is called as a heavy spin. Over here, we are centrifuging for a longer period of time at a very high RPM. Okay, so over here again, you are going to get certain sediments, and that sediment is composed of the platelet concentrate, whereas the remaining supernatant fluid is the plasma. And from this plasma, we derive fresh frozen plasma and cryoprecipitate. So in general, this is the basic method of separation of whole blood. Now, the ones which have been marked in red, okay, these are the components which are usually made use in clinical practice. That is the packed RBCs, platelet concentrates, fresh frozen plasma, and cryoprecipitates. Okay. Now, just to explain you the method in detail, okay, pay a lot of attention over here. So I am again going to repeat the same thing, and I'm going to give you a fair bit of an idea that how the separation of the blood components are taking place. So once you collect, one whole blood sample is collected. After that, what you have to do, that the blood is collected in this main bag. So the first bag in which the whole blood is connected, we call it as the main bag. And this main bag is first subjected to a light spin that I told you. What is the meaning of light spin? When the centrifugation is done for a short period of time at a lower RPM. Okay, so in this case, and remember, this main bag has been attached to satellite bag 1, 2, 3, and so on. Okay, depending on which and how and what components we want to separate. Okay, so after the light spin, I told you what is going to happen. Whatever RBCs was there, that is going to sediment. Okay, the RBCs have sedimented over here like this. Okay, and whatever the supernatant plasma was there, it is now transferred to this first satellite bag. Okay, so after the light spin, what are the two components that we are getting? We are first getting the packed RBCs, yes, in the main bag, and the supernatant fluid was transferred to the second bag, that is the satellite bag number 1, which is now containing the platelet-rich plasma. Okay, now this packed red cell is basically can be stored, okay, for 35 days at 4 to 6 degrees centigrade by addition of a CPDA1. What is CPDA1? I am going to tell you further on in the lecture. Okay, now coming to this platelet-rich plasma. Now this platelet-rich plasma is containing platelet as well as plasma. So now I want to separate the platelets. So what I am going to do, I am going to carry out a heavy spin. Now over here, the centrifugation will be carried out for a longer period of time at a higher RPM. And the result of this is the separation of the platelet from the plasma. So this platelet that is sedimented, this was the satellite bag number 1. If you remember, this was the satellite bag 1. Okay. And this satellite bag number 2, now whatever supernatant fluid was remaining was then transferred to the satellite bag number 2. It is satellite bag number 2. Okay, so the supernatant is now in the plasma. Okay, understood. Now, just like how the packed RBCs can be stored for 35 days at 4 to 6 degrees centigrade, similarly, this platelet, okay, platelets can be stored at for only 4 to 5 days, and they are stored at 22 degrees centigrade under continuous agitation. You have to continuously, okay, agitate. The platelets are kept in an agitator where it is constantly shaking. Okay, and the lifespan of this platelet is just 4 to 5 days. Okay, understand? Now, what happens to this plasma that is remaining? Now, within 8 hours of collection of the whole blood, if the plasma should be separated. Okay, now depending on the next method, we are going to derive either fresh frozen plasma or cryoprecipitate. If this plasma is rapidly frozen at -18 degrees centigrade or lower, okay, if the plasma is rapidly frozen at -18 degrees centigrade or lower, okay, immediately if it is done, then it is called as fresh frozen plasma, and it can be stored till 1 year at a temperature of -18 degrees centigrade or lower. Okay, so this is how we are obtaining fresh frozen plasma. Similarly, if this plasma that we saw over here, this plasma is rapidly freeze at -18 degrees centigrade or lower, but after it has been freezed, it is undergoing thawing. Thawing means we are making it warm again. at 4 to 6 degrees centigrade. So we had rapidly frozen them at -18, and again we brought it back to 4 to 6 degrees centigrade. In that case, we are going to get a mixed white flocculent precipitate along with the plasma, and this mixed solution is now centrifuged, and after centrifugation, whatever sediment remains, that is called as a cryoprecipitate. Now this cryoprecipitate, that is the sediment, it is refrozen at -18 degrees centigrade or lower for 1 year. It can be stored like this. Okay, so just go through this once again and remember how each of them has been obtained, how the cryoprecipitate is obtained, how the fresh frozen plasma is obtained, how we had obtained the packed RBCs. Okay, so this method, which is most commonly method followed in many or maximum blood banks in our country. Okay, this is very important to understand. And why we are calling it as differential centrifugation? Because first we are doing the light spin, and then that is followed by heavy spin. Okay, so thus the centrifugation has been carried out at differential RPM. So that is why we are calling it as a differential centrifugation. Anyone is having any doubt with regards to the component separation method by differential centrifugation? Yes? Any doubt anyone is having, or is it very clear? Okay. So basically, this is the most important part that I wish to make you understand. Now we are going to see the individual components. Okay. So first we are going to start with the whole blood. Now the whole blood, okay, when it is collected, the whole blood is collected in a anticoagulant preservative solution that is called as CPDA1. The full form of CPDA is citrate phosphate dextrose adenine 1. Okay, the total volume of the whole blood that is there in the bag is comprising of 350 ml of whole blood, and to that 49 ml of anticoagulant is added. And which anticoagulant that we have spoken about? This is the preservative solution, that is CPDA1. Now the whole blood has to be stored at 2 to 6 degrees centigrade. The shelf life of the whole blood is around 35 days. Okay, it is because of this CPDA1, the shelf life is 35 days, and it is a very, very important MCQ which is asked. Okay, remember the whole blood has to be ABO identical to the recipient. So for example, if you want to give whole blood to A positive, then it has to be A positive blood only. It cannot be O positive. Okay, it has to be A positive. It has to be identical to the recipient, because it is having not only the cellular component, but it is also having the plasma. So you have to do the exact grouping. Now the transfusion of whole blood is beginning within 30 minutes of removal from the refrigerator, and it should be complete within at least 4 hours. Within 4 hours of starting, you should complete it. Okay. Now whole blood is increasing the hemoglobin by 1 gram per deciliter, or it increases the hematocrit or the PCV by 3%. Okay. Now what is the indication of whole blood? Now remember, in today's world, whole blood transfusion is rarely done. Only there are certain very few indications. It is given in those conditions. It is the first choice of transfusion when there is an acute blood loss. So you require more amount of fluid in your body. So if you have to replace hemoglobin, if you have to replace the RBCs, in that case, you choose the whole blood. So acute blood loss with hypovolemia, in that condition, it becomes the first choice. Even in case of exchange transfusion, when it is done in neonates, maybe they are suffering from any kind of hemolytic picture, they require some exchange transfusion. Then they require whole blood transfusion. And if packed RBCs are not available, packed RBCs, as I told you, it is containing only the cellular RBC component with very little amount of plasma. Okay. Now, remember, it is contra. What are the contraindications? Now, if a patient is suffering from a chronic anemia, okay, and has a compromised cardiovascular function. For example, the person is suffering from CCF, okay, congestive cardiac failure. So already the heart has been decompensated. I do not wish to give an extra amount of blood to the patient so that the volume of the total body fluid increases, and that will put more pressure on the heart. So I don't want that. So in any kind of an elderly person or chronic anemic patients or patients with heart failure, I will avoid the whole blood transfusion. Is it very clear about the indications? So this is how a whole blood, even if it is a whole blood unit or if it is a packed RBC, it will look the same. Now, what is very important, as I told you over there, in around 349 ml, I was adding approximately 49 ml of anticoagulant. Similarly, this is a bag. Now, it varies with different countries. This is a bag containing 450 ml, containing 63 ml of CPDA anticoagulant. Now, different countries have different codes. Over here, the storage temperature is 1 to 6. We have in our country, we follow 2 to 6 degrees centigrade. Okay. Always remember on this packet, see, there is always a unit number. There is a bar coding which is always there. Once you will click at this barcode, it is going to tell you that it is going to identify the donor and all the details of the donor. And it is containing CPDA1 and it is a whole blood unit and it has to be identical. It is ORH positive. Okay, so these are the different findings that you are going to see whenever you look at a whole blood unit, or even if you look at any unit, these details will be mentioned. Okay, is it very clear to everyone about the whole blood? Okay, now the second blood now we are going to, now this was the whole blood. Okay, till now we have not started with the blood cell component. Blood components, as by definition, they are all the components which are derived from a unit of the whole blood. So the first component that we are going to see is the red cell component. And I told you the most commonly used component that we see is your packed RBCs. That is, they are having a high cellularity with very less amount of plasma. And the packed RBCs, if you will understand, we are getting after the first light spin. Okay. So the whole blood, okay, whole blood, if you minus most of the plasma, whole blood minus most of the plasma is going to give you a packed RBC. Now, the hematocrit of a packed RBC is very high. Why? Because it is very dense. It is containing excessive amount of only RBCs with very less amount of plasma. So the hematocrit is very high to the tune of 70 to 75%. That means the packed RBCs are having very high viscosity. So whenever they are transfused very slowly. Okay, very slowly. Just like the whole blood, the packed RBC is also increasing the hemoglobin by 1 gram percentage only. So the contraindications of the whole blood transfusion becomes the indication of RBC or packed RBC indication. So in conditions of chronic severe anemia, or in conditions of severe anemia in a case of a heart failure patients or an elderly patients, okay, where I do not want any kind of volume overload. So in those conditions, I am going to give packed RBCs. Okay. Now the fourth important thing, in case of acute blood loss, also we can use, okay, for example, in case of acute blood loss, along with the packed RBCs, I have to give certain plasma expanders like the colloid or the crystalloid. Okay. In that situation, we have to use certain colloid and crystalloid as well. Now, I told you that the packed RBCs, okay, they are again similarly stored like the whole blood. They will be stored at around 2 to 6 degrees centigrade, and also CPDA1 is added to them, and their shelf life is approximately 35 days. Okay, this is what is usual for the packed RBCs also. Now, very, very important thing, sometimes, okay, the packed RBCs, we can increase the shelf life of the packed RBCs from 35 days to 42 days. And such packed RBCs, we call it as the red cells containing additive solution. Now, excuse me, to enhance the shelf life of the packed RBCs up to 42 days, okay, we are giving certain additive solution, which is called as AS. So we have additive solution like AS1, 3, and 5. So for example, the additive solution AS1 and 5 is containing saline, adenine, dextrose. Along with that, it is having mannitol. Whereas the additive solution 3 is containing the same saline, adenine, dextrose, but it is containing sodium citrate as well. So this is the basic role of the red cells with additive solution, is to just increase the shelf life. Okay. The third important type of the packed RBC is a leukocyte poor red cell. Now, you may not know, but one of the very important thing is whenever anyone is receiving any kind of blood transfusion, it is very common to encounter a febrile non-hemolytic reaction. So that is, there is no hemolysis, But the person who is receiving the blood, the recipient, it is showing some kind of fever and chills. It is very common. It is not that it is very commonly encountered. And this has nothing to do with the ABO incompatibility or something like that. It has to do with the WBCs which are present in the transfused blood. Okay, so the leukocytes present in the transfused blood causes a febrile, non-hemolytic reaction. So they cause fever and chills. Okay. So leukocyte poor red cells means, the definition is those packed RBCs which are containing less than 5 into 10 to the power of 6 WBCs in per bag of PRBC. So basically, how do you obtain this poor, leukocyte poor red cells? So at the time of transfusion, you might use a leukocyte reduction filter. Okay, so only leukocyte depleted RBC packet will go. Or during the time of component separation, you can use, you can just filter it. Or by the process of apheresis, what you will do, so for example, by the process of apheresis, you do leukapheresis. Okay, so you remove that component of the of the WBCs. Okay, and you just collect the RBCs, and the remaining component is given back. So by apheresis, if you are going to obtain the packed RBCs, remember, only this RBC component will come. There is no plasma component will be there, or there will be no other component. So in this particular case, this is called as red cell apheresis. So by these methods, you are going to obtain leukocyte poor red cells. Okay, so by definition, it must contain at least 85% of the original red cell, because in the process of filtration, some RBC is lost, but they should contain at least 85% of the original red cell. So what is the most important indication of this is the prevention of the febrile non-hemolytic transfusion reactions in persons who have received multiple transfusions. So what is this non-hemolytic transfusion reaction? More will be clear in the next classes, okay, that I am going to take when I am going to teach about the adverse blood reactions. Okay. And the very important thing is to prevent HLA immunization or sensitization in patients who are likely to receive allogenic hematopoietic stem transplant or bone marrow transplant. So what we are talking over here, remember, whenever we are carrying out a transplant, okay, remember all of our body cells which are containing a nucleus, they have an antigen called as HLA antigen, which is called as a human leukocyte antigen. It is present in all nucleated cells of our body. And every person, it is like a DNA fingerprint. Every person will have their own HLA. Okay, so when you are transplanting anything between two individuals, okay, so this HLA that you are using, okay, this HLA, for example, if I'm transfusing some blood samples to the other patient, so if that other patient HLA and if my HLA is not matching, so my body is going to synthesize certain antibodies against that particular HLA antigen. So if that person is not undergoing any kind of transplant, it is all right. But if that person is likely to receive any kind of bone marrow or hematopoietic stem cell transplant, in that case, I prefer to transfuse that patient with leukocyte poor RBCs. Okay, because if I give him HLA, if I give him like whole blood or packed RBCs, okay, then the leukocytes in that RBCs can contain HLA antigen, and that HLA antigen can induce any kind of a host response. So it might lead to graft failure. So this is the basic idea why I am giving leukocyte poor RBCs. Okay. The fourth type of RBC that I can give is called as the washed RBC. Over here, the RBC is washed with normal saline. And the basic idea is to remove any WBC, any plasma proteins or antibodies that is there on the surface of the RBC, or even to remove any platelets. Now, what is very important, the most important thing is to remove any kind of antibodies. Okay, why? Because the only indication of giving washed RBCs is IgA deficient individual who has developed anti-IgA antibody. So there are certain individuals who do not have the IgA antibody. Okay, so such individuals, they have developed anti-IgA antibody in their system. So those individuals, if we are giving any kind of packed RBCs also, that is containing some amount of plasma, and that some amount of plasma will contain certain antibodies, including IgA, because we are all normal donors. So all normal donors will contain IgA. So if we, as a donor, if we give IgA, if we give our blood sample to any IgA deficient individual that is having this particular antibody, so that particular individual is going to develop a reaction. So whatever RBCs that we are giving, we will wash it with normal saline. So no antibodies including IgA is not present in that particular sample. That is why we are going to wash it. The shelf life of such washed RBCs is very less, was only 24 hours, okay, when stored at 4 to 6 degrees centigrade. And in the process of washing, around 20% of the RBCs are lost in the particular process. Okay. The next type is the frozen RBCs. Now, frozen RBCs is that RBC which has some alcohol like glycerol is added to the RBC, and that is frozen for minus 65 degrees centigrade. Now, at this particular temperature, this frozen RBC can be stored for the next 10 years. So those who have attended my previous lecture on the blood banking, okay, so you have read about the rare blood group, that is the Bombay blood group. So individuals who are having a very rare blood group, they can in advance give their own blood, and they might ask the blood banking personnel to store the blood in case of emergency, because it is not very easy to find a rare blood group person. Okay. So when you and also the second indication is those individuals who are needing autologous blood transfusion. Autologous means self. Now, for example, I am going to explain what is autologous. So for example, if a person of a Bombay blood group or any rare blood group, he or she wants to undergo a surgical procedure where it is anticipated that some amount of blood loss will be there. So what that person did, that it is not an emergency situation, it is an elective surgery. So what that person was asked, that because the blood group is rare, he was asked to donate some amount of blood 2 to 3 months or 6 weeks, 4 to 6 weeks before the surgery. So he went and he donated the blood. Okay. And after 6 weeks, when surgery was required, and for example, a cesarean section is done. So in that, usually 1 to 1.5 liter of blood is lost. So in that situation, I know that this much amount of blood will be lost. So from before only, I have arranged for the blood. My blood I have arranged. That is why it is called as autologous blood transfusion. I have given my blood to the blood bank, and after 6 weeks, I am using it for myself. Understand? So these are the basic indication of frozen red cells. Okay. Now, once you defreeze this blood after deglycerolization, okay, that means after you take it from minus 65, you thaw it and you bring it to room temperature and you remove the alcohol, the glycerol. How you remove? By adding saline. In that case, the RBC should be used within 24 hours. Okay. When it is stored at 4 to 6 degrees centigrade, it can just go up till 24 hours only. And lastly, we are having what is called as an irradiated red cell. Now, irradiated red cells basically are those red cells which have undergone gamma irradiation of the packed RBCs at 2500 centigrade. Now, what is the main function of this irradiation? It is to inactivate the cytotoxic T lymphocytes. Now, what happens that sometimes, okay, our donor blood, okay, contains viable T cells, and this T cells can go and attack the host. It can attack the host. This is called as graft versus host disease, GVHD. Okay. So in that particular situation, I want to, remove these T cells, and those T cells can be removed by giving gamma radiation. Now remember, the storage it is stored at 4 to 6 degrees centigrade and can be stored for 28 days from the day of irradiation or the expiry date, whichever is earlier. Okay. So the basic indications of this is, number one, it is done in those individuals, okay, whose immune system is not developed. So the T cells from outside can go and attack the body. So in those individuals, we are going to give this. So the first indication is intrauterine or premature neonatal transfusion. So premature, so a neonate which is prematurely born, immune system is not developed. In the intrauterus, the neonate is not developed. So the immune system is not working properly. So if I am giving transfusion, I should give irradiated blood. Okay, so that whatever T cells are present in the blood component don't go and attack the neonate or the fetus. Second, in individuals with immunodeficiency, it is it is desired that we should give irradiated RBC sample. Now, most of these points that I have read, for example, irradiated red cells, frozen red cells, washed RBCs, leukocyte poor RBCs, red cells with additive solution, okay, all these that we are reading about, okay, these are rarely used. At least in our country, it is rarely used. So most of the time, it is only the packed RBC which is maximally used. Okay, so this is just for theoretical purpose, and for your exam purpose, I am giving you all these things. Okay, RBCs in additive solution, leukocyte poor red cells, washed RBCs, frozen red cells, irradiated red cells. Now, what I want from you people, absolutely, I understand that most of you people are associated with medical college. So you go to the blood bank of that concerned college. Okay, just go one day, just for half an hour, 1 hour, you go, and you go into the room where they are doing this component separation, and see all the different units of blood that is contained over there and how it is working. See, whatever I am telling you, if you see in the practical portion, you are going to remember it for your life, and you will understand it much better also. Understand? So everyone, you are having access to the blood bank, so do visit the blood bank, okay, and see what all units are available in your particular blood bank. Now, if you see over here, this is again a packed RBC as we are looking at. Okay, so again, it is the grouping over here is there, barcoding is there, date is also given over here. Now, if you see over here, there is something called as, can you see? It is AS1. I don't know if you are able to appreciate. Can anyone see it is AS1 over here? And there is also one thing written over here. I am going to just read it out. It is leukocyte. It is leukocyte reduced. Okay, so probably this is from a first world country where we are looking at a leukocyte reduced blood sample. Okay, is this very clear to everyone? So whatever details are there, it is already available over here. Okay, it is already available over here. Okay, is this very clear to everyone? Okay. Now comes the second component. So the first cellular component we have already come across, that is the RBC component, and we have read in details about the RBC component. Now we are going to understand about the different platelet components. Now, platelet components can be, obtained by two methods. So we have already seen the first method of platelet, separation, that is the differential centrifugation. The other method is platelet pheresis. So the first method is to obtain the platelet concentrate. Okay, it is prepared from the whole blood by the process of differential centrifugation. First, the whole blood is made to undergo the light spin. So we get the packed RBCs and platelet-rich plasma. Then the platelet-rich plasma is subjected to heavy spin, and then we are getting the platelet concentrate along with the plasma component. So the platelet concentrate obtained by differential centrifugation is called as the platelet concentrate. The second method is the platelet pheresis. So what is the platelet pheresis? Let me just show you about the apheresis. So before I go anywhere, this is the method of apheresis. Okay, and this is the machine over here that you are going to see. This is the this is the apheresis machine. Okay, this is the classical apheresis machine that we are looking over here. So if you see basically from one channel, if you see blood is going over here, whatever component is required, if you see, it is separated. And then the remaining blood, if you see, it is again going via this sample back to the individual. So for example, if I just require the platelet, only the platelet component will be separated. In that case, the process is called as platelet pheresis. If, for example, just the plasma is required, we will call it as plasma pheresis. If, example, only the RBC is required, we will call it as red blood cell apheresis or red blood cell apheresis. If the WBCs are just required, it is called as a leukapheresis. Okay, so this is the other method of separation that is called as apheresis. Okay, clear to everyone? Okay. So basically in platelet pheresis, so always remember the platelet concentrates. Okay, remember it is also called as the random donor platelets, or we call it as RDP. Because over here, why we are calling it as random donor platelets? Because what we do over here, from 4 to 5 individuals, we take the platelet concentrate, we mix it together, and then we transfuse. That is why it is called as a random donor platelet. Whereas the platelet pheresis is called as SDP, or single donor platelet. We call it as SDP. What is the reason that we are calling it as SDP? Because from a single donor, okay, it is attached to the blood separator machine. The platelets are separated from here and retained, okay, and the remaining component is returned back to the donor. This is called as apheresis or platelet pheresis. Okay, so because the platelet has been obtained from a single donor and is used from a single donor, it is called as single donor platelets, also called as apheresis platelets. So basically, if we look at the platelet concentrates obtained by the differential centrifugation, you will see the unit is kept at the room temperature. As I told you, the temperature is 20 to 24 degrees centigrade, and platelets must be separated from the whole blood within 6 hours of collection. Now, how it is done? As I told you, by differential centrifugation, by light and heavy spin. Now, at the end, what we get 50 to 60 ml of plasma containing platelets. Very less amount of plasma is there containing platelets. It is stored at 20 to 24 degrees centigrade with continuous agitation, and the lifespan is only 4 to 5 days. Now remember, 1 unit of a platelet can increase the platelet count only by 5,000 per microliter. So 1 unit of RDP, that is random donor platelet, will just increase the platelet count by 5,000 per microliter, and it is containing just 50 to 60 ml. Okay, so very importantly, okay, 1 unit is not sufficient. So the usual adult dose is 4 to 6 unit of random donor platelet. So for example, individual A, 1, 2, 3, 4, 5, 6. So these are 6 different individuals. Okay, from there, whatever RDPs was obtained, okay, they are mixed and they are pulled together. So any one RDP is containing 50 ml. So 6 people will have approximately 300 ml. Okay, so that 300 ml is a dose. So all this together, 4 to 6 units are pooled together, and then they are basically infused in the individual within 4 hours. And because they are taken from different donors, that is why the term of this unit is called as random donor platelets. Okay, so if 1 unit is increasing by 5,000, so 4 to 6 units will increase the platelet count by 20,000 to 40,000 per microliter. So if I ask you what is the normal platelet count of an individual, yes, it is 1.5 to 4.5, or sometimes 4 lakh per microliter. 4 lakhs per microliter. This is the usual platelet count. So, and what is the indication? When are you going to give the platelet? When the count becomes less than 5,000 per microliter, that is the indication for giving the platelets to the patient. Okay, is it very clear to everyone? Okay. This is all about your random donor platelets. So when we come to the single donor platelets, I have already discussed, okay, how this platelet is being collected. Now, what is the advantage of the single donor platelet? Now, since we are only collecting or harvesting the platelet from a single donor, so in a single unit, okay, large number of platelets can be obtained just from a single donor. So in one sitting of apheresis, you can collect, okay, equivalent to 6 units. Okay, 6 units of RDP means equivalent to 6 units of RDP. That much amount of platelet you can get just from a single donor. Okay, very important. So very important thing is, with this method, it decreases the exposure. It decreases the exposure of the recipient to the donor. So less amount of, donor platelets are exposed to the recipient. So the recipient doesn't develop any kind of antibody to the donor platelet, because I'm using just a single. So maybe if I'm pulling the platelets from 6 or 7 donors, maybe the recipient is going to develop platelet refractoriness. That is, it might develop antibodies against the platelets. So basic indication of this SDP or single donor platelet is it is suitable when the patients have developed allo antibodies, or they have developed antibodies against the donor platelet HLA antigen from a previous transfusion. So if the individual has already developed antibodies against the platelet, so whatever platelet you may give, the random donor platelet, the recipient, they are going to attack that platelet, and the platelet count will not increase. So you have to match, you have to HLA match the platelet. So the HLA of the SDP, that you will give should match with the HLA of the recipient. So you have to give the HLA matched platelets to the recipient in that case. So only in those individuals who have developed antibodies against the platelets, I am going to use the SDPs. So now what is the indication? What is the indication of giving the platelets? Okay, absolutely, when there is a bleeding which occurs because of decreased platelet production. Now, can you tell me what are the causes of thrombocytopenia, decreased platelet production, when the platelet production will go down? Yes, can anyone tell me? In any condition, bone marrow occupying lesion.
Of malignancy.
In case of leukemias, very good. In case of leukemias, pancytopenia like aplastic anemia. Okay, in these conditions, I'm going to give. So any condition of reduced platelet production, I have already taken this lecture on thrombocytopenia. So you should understand what are the causes of decreased platelet production. Bleeding which is occurring in a hereditary disorder of platelet function. Yes, can anyone name an example of disorder of platelet function? There were two platelet function disorders very commonly known. Yes.
ITP.
Platelet function, I am telling, not destruction. If you remember, platelet function was altered in Glanzmann thrombasthenia and also one other condition. Yes, Bernard-Solier syndrome. So go back and read, you have to revise. And thirdly, in conditions of massive blood transfusion, also platelet transfusion is indicated. Now remember, you should never, although there is reduced platelet count in conditions of TTP, that is thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, platelet transfusion is absolutely contraindicated in both these conditions. Why? Because both these conditions are thrombotic in nature. They are thrombotic and they produce microclots throughout the body. So if you are going to give platelets, it is going to further cause more thrombotic tendency because platelets are going to aggregate. Okay, so as a result, there will be thrombotic disaster. There will be infarction, thrombosis, embolism. So to prevent this thrombotic thing, we should never give platelets to persons of TTP and HUS because the pathology is completely different over there. Okay, because the bleeding in TTP and HUS is because of excessive consumption of the platelets to form clots. Okay, so we have to prevent any kind of platelet transfusion in TTP and HUS. So this was the second cellular component, that is the platelets. Now we are going to understand about the plasma components. So we have already seen that how the plasma component is separated. So if you are going to freeze the plasma component at -18 degree or colder, okay, for 1 year, you are going to get the FFP that is stored for 1 year. And if you are first, freezing to -18 degree Celsius, and then again you are re-thawing it, you are making it warm again to 2 to 4 degrees centigrade. And again, if you centrifuge, after that, whatever sediment you get, that sediment is a cryoprecipitate that we say. So we know already how we are getting this. So over here in the plasma component, let us see what are the features of fresh frozen plasma. So they are containing all the coagulation factors, including the labile coagulation factor. Labile means one which is sensitive. In Hindi, I call it as nazuk. That is, it is very sensitive or nazuk. Okay. So that is labile factor 5 to 8. In short, I will tell you, these are the factors, number 5 and 8 are the first to get destroyed. Okay. That is why they are called as labile clotting factors. Now, when you want to transfuse a fresh frozen plasma, it has to be thawed at a temperature of 30 to 37 degrees centigrade. And this process takes 30 to 45 minutes. Then it can be stored at 2 to 6 degrees centigrade, but it has to be used within 24 hours, provided it is stored under 2 to 6 degrees centigrade. The dose is around 10 to 20 ml per kg. So approximately 3 to 6 units are, is the dose for an adult patient. So what is the indication of FFP? As we understand that FFP is containing a whole amount of, coagulation factors. So in multiple coagulation factor deficiency conditions, like in case of liver disease or in condition of warfarin overdose, so we can give FFP. It is replacing the coagulation factors. In consumptive coagulopathy like disseminated intravascular coagulation, in inherited deficiencies of clotting factors for which no specific factor replacement is there. So you might give FFP in that condition. And also in case of TTP and HUS, the treatment of choice is FFP and not platelet transfusion. You should give FFPs. Okay, that is the treatment of choice in case of TTP and HUS. Now coming to the discussion of cryoprecipitate. What is the content of cryoprecipitate? It contains factor number 8. It contains von Willebrand factor. It contains fibrinogen factor number 13 and fibronectin. Now, when you want to transfuse a cryoprecipitate, it has to be thawed again at 30 to 37 degrees centigrade, and it is stored at 2 to 6 degrees centigrade, but it should be used within 6 hours. Okay. Now, for the cryoprecipitate to be useful, it should contain at least 150 milligrams of fibrinogen and more than 80 international units of factor number 8. The indication, the two most important indication of cryoprecipitate, which you should say first, you should give them in conditions where there is a deficiency of fibrinogen or there is a deficiency of factor number 13. These are the two important indications. It might be used in conditions of von Willebrand disease and hemophilia A also, in case the factor number 8 concentrate is not available. In case the specific factor concentrate is not available, it might be used for von Willebrand disease and hemophilia A as well. So I feel it is completely clear what is FFP, what is cryoprecipitate. Yes. Now I just wanted to show you, remember, this is a platelet. This is a bag of platelet that we had read. Now, any kind of plasma solution, be FFP, be cryoprecipitate, they look like this yellow color. Now, if you see over here, they have written, this is an apheresis platelet. It is an apheresis platelet, which is leukocyte reduced. Okay. Apheresis platelet. And again, the blood grouping has been written over here. Okay. Now, the next component is the plasma derivative. Now, this is a favorite question of the examiner. Whenever they will ask you, they want to ask you questions from the blood component, they will either, if the examiner is very lenient, then he will just ask you, you know, what are the different blood components? Straightforward questions will be asked, indications, contraindications like this. But if the examiner, you know, if he is not a straight one, if he wants to ask you difficult question, this is the favorite question. They will ask you what is plasma derivative, because no one remembers this portion. They think, acha, what is plasma derivative? Okay, I cannot, you will not be able to understand also that he is asking you a question from blood component. So remember, plasma derivative, that means something I am obtaining from the plasma. It is obtained by fractionation of large volumes of pooled human plasma. And this and whatever this this part of whatever fraction of this plasma that I am taking, for example, I want to obtain plasma proteins. I want to obtain one important protein like albumin. So that part I will fraction it. That is why we are calling fractionation. And whatever component I'm taking, I am inactivating. I am heat and chemical inactivation is done so that the viruses or any bacterial component or any other component, microbial component, has been inactivated and killed. So the first important plasma derivative is the human albumin solution. Now it is basically used in conditions of replacement fluid in therapeutic plasma exchange. When I want to remove the plasma, for example, certain unwanted autoantibodies are present in the plasma. So I want to remove that plasma and I want to give fresh plasma to the patient. So in that case, I can, in the replacement fluid, whatever I'm giving, instead of giving a plasma, I'm just giving human albumin solution to the patient. For example, I have taken 100 ml of plasma out of the patient, 100 ml of human albumin was injected into the patient. So as a therapeutic plasma exchange, it is also used in the treatment of diuretic resistant edema of hypoproteinemia. Now you all remember that one of the main causes of edema is hypoproteinemia. If you remember, there is in the blood, there are two forces. One force is the hydrostatic pressure, which is acting outward. One is the inside pressure, that is the oncotic pressure, which is acting inwards. Yes, everyone is going to remember. Now, this oncotic pressure is because of what? Because of plasma proteins. Yes, it is because of plasma protein. So in any condition, when the plasma protein will become less, this inward force will become less. So as a result, more amount of fluid will be lost, and that is going to lead to and that is going to lead to edema. So for edema, the drug of choice that we use is loop diuretics. Okay, so we are using diuretics, loop diuretics, or thiazides we are using. Okay, so basically if we are using these diuretics and if it is not being able to control the edema, then the basic problem over here is reduced amount of plasma protein. So the most common plasma protein is albumin. So what I am going to do, I am going to inject this albumin in those individuals who are resistant to diuretics. Okay, to correct the underlying cause, I am giving this human albumin solution. It is only given in very severe cases of edema. For example, if a patient is having any severe liver disease or any severe kidney disease, if you remember, all these disease are at the heart of causation of edema. If you have read the chapter of edema, you are going to recall. Okay, so in all these conditions, I am going to give this because in this condition, there is a decreased levels of plasma protein in the body. The second thing is the factor 8 concentrate that can also be obtained from here. So this concentrate, it is used. This is the first choice when I want to give, when I want to treat hemophilia A, that is because of factor 8 deficiency and von Willebrand disease. So the first choice of treatment should be factor 8 concentrate. There is something called as a prothrombin complex concentrate, which is containing certain factors like 2, 7, 9, 10 and protein C and S. Now, what is common among these factors? Yes, can anyone tell me what is common among them? Yes, all of them, they are vitamin K dependent coagulation factors. Yes, so they are given in any condition where there is a deficiency of factor number 9 or factor number 2, 7, 10, okay, or there is factor deficiency of factor 8, or those individuals who have developed antibodies against the factor 8 concentrates. So in those individuals, we can give prothrombin complex concentrates. Now, the fourth most important plasma derivative that we are using in our day-to-day life is the immunoglobulins. Immunoglobulins, when I'm saying, that means the antibodies, the pre-prepared antibodies. Okay. So passive, so there are two types. Okay, one is non-specific type, wherein an antibody is not specific against any antigen. So for example, in passive prophylaxis of viral infections, as in hepatitis, rubella, measles, we are giving certain, antibodies. Okay, this is very non-specific. There is a treatment of hypogammaglobulinemia. In some individuals, antibodies are not produced. So we give antibodies, okay, immunoglobulins are given. In case of severe infections like neonatal sepsis, to save the life of the patient, so we are giving antibodies, as well as in case of autoimmune thrombocytopenic purpura also. When the steroids are not working, then we give antibodies which are going to kill those antibodies which are killing the platelets. Antibodies against antibodies are given. But these antibodies are, that we also call it as, this non-specific, we call it as IVIG, intravenous immunoglobulins. You will read it across many topics in medicine and surgery, the use of IVIG. Okay, so one very important thing that is there now in pandemic, that not in the third wave, when I was working in the first wave and in the second wave of the COVID-19 pandemic. So some patients, okay, for example, I also suffered from COVID-19. So whoever suffered from COVID-19 and they recovered, okay, so absolutely my body is having certain antibodies against the COVID antigen. So we were asked to go to the blood bank and to donate the plasma. Okay, we were asked to go to the blood bank and to donate the plasma. So in this situation, what happened, that because we were asked to go, and so what was the basic use? We wanted to take that antibody that was present against the COVID-19, and that antibody, the plasma antibody, this is a plasma derivative, that antibody will be used specifically against the COVID-19 antigen. And in whom? In patients having severe infection who are not responding to steroids and not responding to heparin. So in those individuals, we are giving this specific antibodies, okay, against COVID-19. So what is the importance of antibody? That they are acting absolutely instantly, because antibodies are instant. Because if we are giving a vaccine, okay, that is containing some antigen, that for that vaccine to become effective, it requires at least 2 weeks. That is why if you see the latest guideline, after you receive the COVID vaccine, and if you have the COVID vaccine certificate, they are writing that at least 15 days should have gone surpassed, then only that vaccine certificate can be used for travel purpose. Why they are giving this 15 days? Do you know? Because this is the time which is required for antibody formation, and then only I can say that you are immune to COVID-19 infection. Then only that vaccine certificate will be accepted. Understood this part? That is where the immunoglobulin. Now these immunoglobulins, this can act instantly. They can act instantly because they are antibodies. Okay, they are antibodies. Now there are certain specific immunoglobulins. Okay, now these are obtained from donors who are having very high levels of IgG immunoglobulin, and these are antigen specific. They're specific against something. For example, we are using anti-D immunoglobulin in Rh hemolytic disease of the newborn. When there is a Rh negative mother, Rh positive fetus, so to prevent the sensitization, okay, of the mother with the Rh positive fetal cells, we are giving anti-D immunoglobulin. The second thing, and this is given to the mother. This is given to the mother. Okay, now there is a hepatitis B immunoglobulin. Okay, that is also given in case, for example, you have a pinprick, or if you have a false blood transfusion is there and you got a Hep B positive blood. In that situation, varicella zoster immunoglobulin is there, tetanus immunoglobulin. Now whenever we get some for example, we get a cut, so we go to the emergency and we take the injection TT. Now this TT is a vaccine. Okay, this is a vaccine. So in case your cut is very small, so it is all right, this vaccine is going to work. But in case your cut is very deep, for example, an iron rod went through your whole skin. For example, you had a bike accident, there was a very severe cut and it was completely soiled. So at the local site, in addition to the TT vaccine, at the local site, you are going to give tetanus immunoglobulin as well. You're going to inject tetanus immunoglobulin at the local site, because instantly you want the antibodies to go and kill any organism over there. Maybe there is a tetanus, there's a clostridial organism that might be there and it might cause death of the patient. Similarly, okay, if there is a dog bite, we are giving the rabies vaccine. But if the dog bite is very high grade, grade 3, grade 4 dog bite, very deep is there, then again at the local site, along with the vaccine, we are giving rabies immunoglobulin at the local site as well. Okay, is this understood about the plasma derivatives and the antibodies that we are deriving from it? And lastly, okay, I wanted to speak about the recombinant factor concentrate. That is when the factor concentrate is produced by recombinant DNA technology. So what does it mean? That for example, the gene that is used for producing, for example, for production of the factor 8 concentrate. Okay, if that gene we take and we insert that gene in a rabbit or in a mice, okay, so in that, and then the rabbit or the mice is starting to produce that particular that particular factor 8. So that when it is produced in the rabbit, and then we are collecting that factor concentrate from the rabbit or from the rat, so that becomes from the recombinant DNA technology. Okay, so this is very very highly specific, very nice, but it is very expensive. So for example, factor 8 recombinant factor 8 concentration used in hemophilia A and von Willebrand disease, and factor 9 concentration is used in hemophilia B. So with this, we have completed in details everything about the blood components, including apheresis. I think we have discussed. Okay.